one of the 4 neurosurgeons working at Dr. Farooq Endoscopic Spine Institute. I am in practice for last 12 years. 90% of my cases is spine. All lumbar discectomies and laminectomies are performed through a percutaneous full endoscopic spine surgery, that is stitchless surgery, at my institute. So my past experience in spine surgery, initially I started with the deformity correction, then I switched to TLF and PLF, then epidural steroid injections, transforaminal facet joint and SI joint injection, then kyphoplasty. Lastly, I developed a tubular endoscopic discectomy. After that, I switched into the full endoscopic spine surgery. Okay, Carly. So I done my fellowship in endoscopic spine surgery from South Korea. Then I attended multiple cadaver workshops. Made a full endoscopic spine setup in Peshawar in 2017, first case in 2018. Then further, I refined my training in full endoscopic spine surgery. I went to China. Religiously, I started full endoscopic spine surgery and started my transforaminal surgery experience under the guidance of Dr. Tonch Coach from Turkey, he is present. I'm much thankful to him. Recently, I did my UB fellowship from People's Republic of China. So these are the objectives of my presentation. So if you talk about the history of spine surgery, so the first operation for rupture intervertebral disc was carried out by Max and Barr in 1932. Then Lowe and Wash, who initiated a more minimal bone removal and extradural discectomy in 1939. Then the era of Yassergel, who introduced a microscope for a discectomy and called it a microdiscectomy, and still it is a gold standard for a disc herniation. Then Cambin, who first endoscopically visualized the herniated nucleus pulposus. In 1990, Cambin introduced the anatomical understanding of a transforaminal approach in triangular safe zone, where a lesion can be approached without any neural damage. Then Young, who from Arizona, developed a spatial system with constant irrigation and call it a YES system. And lastly, Rutin, who further refined the full endoscopic spine surgery through transforaminal and interlaminar approach. Okay. So So if we talk about the full endoscopic spine surgeries, here is an article published by Sebastian Rutan, and who described that full endoscopic lumbar surgery describes an operating technique for a spinal canal and neighboring structure carried out continuous visual control and irrigation using an approach causing a minimal trauma. So this is an endoscopic, this is not an endoscopic assisted through a tubular retractor, but a uniportal technique using endoscope with intraoperative working channels. So for endoscopic spine surgery, we need the 3 main components. One is endoscope, which provides clear visualization. The second is working channel to deliver energy for coagulation, tools to resect and retrieve loose fragment. And the third is irrigation system, that is constant inflow and outflow of the saline to clear the debris and the clarity of visualization. So here is an article which shows the outcome of full endoscopic discectomy compared with open microdiscectomy and tubular microdiscectomy for a lumbar disc herniation. A meta-analysis published in the Neurosurgical Spine Journal in 2019, and it concludes that if we look at the open and tubular microdiscectomy, the endoscopic discectomy has a less chances of durotomy. And the clinical outcome, length of the stay is less in endoscopic spine surgery. Return to work is faster, while the leg visual ALAC score and the back is more favorable in endoscopic spine surgery, while the CPK and CRP is less in full endoscopic spine surgeries. Another article published in European Spine Journal published in April 2020, complication rates of different discectomy techniques for symptomatic lumbar disc herniation, a systemic review and meta-analysis conclude that compared with open discectomy and microdiscectomy, result of this meta-analysis suggests that endoscopic has a lower risk of overall complication and lower risk of complication necessitating conservative treatment. So this is multiple randomized trials demonstrate non-inferiority of the full endoscopic spine surgery for lumbar disc herniations. Punjabi et al. Tell us that if we go posteriorly for a foramina, so it will increase the size of the foramina with increase in stability. But if you go transforaminally through full endoscopic spine surgery, it will increase the foraminal area without giving any instability to the spine. Endoscopic spine surgery basically has two approaches. One is interlaminar and the other is transforaminal. So full endoscopic spine surgery, for interlaminar approach, we can choose any level in the lumbar spine, that is from the L1 to L5S1, and it is more feasible for paracentral disc herniation, and 70% of the pathologies can be dealt with this approach, and we prefer general anesthesia for interlaminar approach. While talking on a transforaminal, it is more feasible for the level cephalad to the L5S1, and it is more favorable for huge central disc herniation, foraminal, extraforaminal disc. 30% of the spinal pathologies can be dealt with this route, and it is under local anesthesia. So if we look at the evaluation of a surgery for lumbar disc herniation, initially a bigger excess, then microdiscectomy, a unilateral approach, and lastly a smallest excess, that is endoscopic discectomy. So if you look at these, so open laminectomy, then microdiscectomy and full endoscopic spine surgery, hardly you can appreciate the scar on the back. So why endoscopic spine surgery? You all know about this, that outpatient procedure, actual problem addressed, and less chances of instability, leaves you options if you are not satisfactory. Minimal invasive spine surgery, no air contact with the operation site, so less narcotic use post-operatively, and less surgery means less pain, minimal blood loss, and minimal scar tissue formation. The most important thing is this slide, that epidural scarring. It is a natural healing process followed by a spine surgery if we go from posteriorly. But it is frequently associated with failed back surgery syndrome. Aside from contributing to a poor surgical outcome, epidural fibrosis leads to increased complication rates in revision spine surgeries. And the other important muscle is multifidus muscle. It is the major posterior stabilizing muscle and primary responsible for dynamic instability of the spine. Endoscopic spine surgery proves to cause less damage as it is minimal invasive, hence securing the multifidus muscle, resulting in less chances of instability after the surgery as compared to the conventional approaches. So initially it was thought that the sun is revolving around the earth, but then a scientist, European scientist, who proposed that actually the earth is revolving around the sun, and this is a paradigm shift. Initially it was thought that a big incision will give a big results, but now a small incision can deal with all depth pathology with the bigger incision. Talking about transforaminal, we should know about the Kembin's triangle, anteriorly bordered by the exiting nerve root, inferiorly by the end plate of a lower vertebra, posteriorly bordered by SAP of lower vertebra, medially bordered by traversing nerve root. So transforaminal endoscopic discectomy, it's perhaps the most difficult, the most important endoscopic procedure to learn due to different techniques and inconsistent teaching. Patient selection is critical to overcome the learning curve. You need 20 to 25 cases directly supervised to learn the transforaminal endoscopic discectomy. Why we should master the transforaminal endoscopic discectomy? It is the least invasive discectomy approach currently available. No bone or flavum removal, no root retraction. It is the first step toward a much wider application of the transforaminal approach, which is the most stability preserving, nerve protecting, and adhesions preventing and adhesions avoiding approach. So you have to be careful to do a transforaminal surgery at L5S1 because in a male patient is a high iliac crest, so you can't target that foramina through a transforaminal approach. And high grade in cranial migrated disc is difficult. Aside from these, any disc hernia in the lumbar and thoracic spine can be safely and effectively removed by the transforaminal approach. Before doing a transforaminal surgery, as talked by Dr. Ton's coach, you need to see the foramina, because if you darken the foramina and the foramina is stenotic, so you can harm the exiting nerve root. But once you get expertise and doing transforaminal surgery, so before going inside the foramina, you can do a foraminoplasty to decrease harmness to the exiting nerve root. But don't get confused. Do a few cases, just like L4-5 paracentral non-migrating disc, then fill in the gaps by expanding the indication to other levels, migrating disc, far lateral, recurrent disc, and cases with a tight lateral recess. So the key steps in the transforaminal surgery, you need two things. One is image intensifier and the other is endoscopic system. The image intensifier, because you have to calculate your needle entry point and then the needle landing point and reaming of the SAP to allow ducting of a working cannula and the lateral recess. And then you need an endoscope to identification of the compressed nerve root to safely find and completely remove a disc fragment. So for endoscopic spine surgery, you need an endoscope. We use a 4.1 mm working channel endoscope, 2.5 to 4 mm instruments, disc removal forceps, Carrison, punch, pen-filled dissector. We need a radio frequency cartridge to carterize the tissues, and we also need a burr, endoscopic burr, to enlarge the foramina. Usual setup for endoscopic spine surgery. Position of the patient is prone, pillow under the abdomen, under the chest and pelvis to free the abdomen. And about anesthesia, local anesthesia with constant sedation is most preferable. No general anesthesia, epidural anesthesia or spinal anesthesia. Play. Okay. So how you calculate your entry point for a transforaminal approach? You need two images. One is AP and the other is lateral. An AP image, you draw a line which is called a midline or spinous process line. And then you draw another line, an AP image, which is called discal line. So these two lines should take on the AP images. Then put your fluoro on lateral and take in disc inclination line. Disc inclination line means that you take your line from interior of the disc to the surface of the skin and measure this distance. And if you measure this distance, this is basically the measurement from the midline to your entry point. So for transforaminal discectomy, you need these three lines. One is line M, midline, line 2, discal line, line 3 is disc inclination line, and then you calculate it for your entry point. Play it. So how you can calculate? Just like this. On the AP image, you take a center line, this is called line A. Then you draw another line which is called discal line, line B, and the third one is disc inclination line. So this is line A, line B, and this is on the lateral fluoro. Take a third line which is called disc inclination line, and this is basically the measurement for your entry point from the mid of the spinal process to the lateral side, just like this, and you measure it. And this was a reherniation case posteriorly done previously, and then we go through a transforaminal approach. Next. Play. Then after calculating your entry point, this one, do a local anesthesia, infiltrate into the skin, subcutaneous tissue, and along the path where you are working. And then you need a cannula, which is 18 gauge cannula, 25 centimeter long. Then you introduce it, and you should duck on the SAP of the foramina. Next. Next. Slide next कर दे. Okay. Okay. So once you duck your cannula at the foramina, so your landing point should be at the medial pedicular line on AP. As you can see, this is a medial pedicular line. So your tip should not cross the medial pedicular line on the AP. On the lateral, it should not cross the posterior vertebral line. So this is a perfect landing point for your surgery. Why medial to the pedicle line? Because the dura is 1.5 to 2 mm away from a medial pedicular line. So then we play. Once we put our cannula inside, then we remove the stylet and insert a guide wire and remove the cannula. Next. And then over the guide wire, we put on the dilator into the foramina and duck it to hold it in the foramina. Next. Next. Slide next. Then after inserting the dilator, you should take an AP image and you look at this. Your dilator tip should not cross the medial pedicular line, and this is basically your landing point. Next. Then we insert the cannula over the dilator, and then we remove the dilator. Once we insert the cannula is bevel shaped. So initially the bevel is facing upward, but once you hit the bone, the SAP, then you rotate 130 degree and put it into the foramina to avoid injury to the exiting nerve root, and then you are safe. And once your cannula your working sheath is inside, then you can you stop here? Just this is the first look of your endoscopic for a transforaminal surgery. This is the traversing nerve root. This is the pedicle at 9 o'clock. This is the cranial at 3 o'clock, and this is the disc at 6 o'clock. So initially you use your cautery to coagulate the things, to identify your anatomy. If your anatomy is clear, so then you can remove the disc very safely. Next. Yes. And then you can remove a big herniation through a small channel without giving a collateral damage. Next. So during the surgery, we also can talk with the patient to move the legs, and especially the Chinese, they're doing the transforaminal surgery in the lateral approach. And they tell the patient, if patient having a restricted SLR, they ask the patient to raise their leg, and they confirm that the decompression is complete. So is for open surgery, endoscopic spine surgery have also a list of complications, that is dural tears, intraoperative bleeding, postoperative hematoma, incomplete decompression, nerve injury, paresthesia, and recurrent disc herniation. So this is Dr. Ton's coach at my third international endoscopic spine workshop. In at live case, we remove a big chunk of disc. So this is pre-op MRI, huge disc herniation. You can see on pre-op MRI, and this is a pre-op axial images. And the post-op MRI, you can see clearly. And the most important, the beauty of endoscopic spine surgery, if you look at the structures around the disc, so all the structures are preserved. This is a pre-op, post-op pictures. This is another huge disc herniation, pre-op MRI, post-op MRI, and you can see this is in, if once you master in through a transforaminal approach, then you can do upward migrated, downward migrated disc. As you can see, this is a downward migrated disc, and this is a post-op MRI. So these are my research articles. And in conclusion, endoscopic spine surgery is a stitchless, scarless, and a bladeless spine surgery. Minimize collateral damage, preserve normal anatomy, it reduces overall stress to the patient, and at the same time, you achieve the same goal of open surgery. And thank you so much. Thank you. Okay. Thank you.
How much maximum disc can you have?
Depend.